and giving us a very good summary of the topics that have been covered on this cervical cancer webinar series that we've been having. Like we all know, January is a cervical cancer awareness month, and we are glad that the Ministry of Health, through the National Cancer Control Program, partnered with the Kenyatta National Hospital and the University of Nairobi Faculty of Health Sciences to bring us this webinar series. Good afternoon, good evening, because I'm meant to understand that we are having participants from across the globe, from wherever you're catching us. I'd like to welcome you to today's webinar series that will be talking about cervical cancer diagnosis and treatment. As Nelson has just introduced me, my name is Mr. Solomon Omare. I'm a senior oncology nurse working at the Oncology Center of Kenyatta National Hospital, and I'll be moderating today's discussion. My fellow panelists and all those that are joining us, we are all aware that cervical cancer remains one of the most preventable yet deadly cancers that we have, particularly in the low and middle income countries. The good news is that early diagnosis, appropriate staging, and timely treatment can save lives. So today's session is designed to strengthen our understanding on the diagnostic pathways and accurately and how we can have evidence-based treatment decisions based on different stages of the disease. We are privileged to have an expert panel that will bring us the clinical, diagnostic, and treatment perspectives. It's worthy to note that our panels have a varied and wide experience working with cancer patients, and some working at the policy level at the Ministry of Health. I'm glad that Nelson has shared to us about the housekeeping rules. Kindly, not unless you are allowed to speak, kindly keep your microphones muted and only share your question and answer should there be any through our chat box sessions, plus all the many housekeeping issues that Nelson has given us. Without any further delay, it's my pleasure to introduce our first speaker at this time. Our first speaker is Dr. Mudua. Dr. Mudua is a general pathologist. She's worked both at the Moi Kibaki Hospital, Daya, and the Kenyatta National Hospital in the departments of forensic and hematology and blood transfusion. Currently, she's working in the Division of Cancer and Communicable Diseases as a program officer supporting Pillar 2, which is diagnostics at the National Cancer Control Program, and offers histopathology services at the National and Forensic Laboratory. Dr. Mudua, if you are allowed, kindly unmute and start your presentation. It's a pleasure to have you.
Okay, good afternoon, everyone. I hope you can hear me. I'm sorry, there is some background noise. I'm in the office and somebody has decided to start welding right now. But I hope you can hear me and the background noise is not distracting. Nelson?
Yes, precisely, we can hear you, Daktari.
Okay.
Yeah, loud and clear.
Okay, can you see my presentation?
Yes, it's on the screen.
Okay.
Yeah.
Thank you. So as earlier stated, my name is Dr. Muthua. I'm a pathologist. I work with the National Cancer Control Program, and I also work in the laboratory that is being set for histopathology services here at the National Lab. So without much ado, I'll start my presentation. So my presentation today will be looking at laboratory diagnostic on cervical cancer. So we look at the grand overview, what services that does laboratory offer on cervical cancer. So the first part we do is technically the screening just before we go to diagnostics. So the screening at the moment in Kenya, HPV testing we know is the gold standard, which is a molecular-based test, and it's given to people above 30 years. And then we have the second test that is offered for screening, laboratory-based, which is the cervical smear, popularly known as the pap smear, which is a cytological test. And this one, all age groups, but in our screening guidelines, we target those age less than 30 years. And what we forgot is to put in the screening guideline is persons above 49 years. So today, I'll still talk about a bit of pap smear, but also diagnostics. And I'll focus more on laboratory. And knowing that we are a bit of a mixed group, I won't go into too much details, but what I will put across is what like the take-home messages that I'd like all of us to have, whether in cervical cancer or any other cancer when it comes to diagnostics and laboratory. So this is my overview for today. I'll go through something small on anatomy. Anatomy is very important, and the indications for biopsy. And during the indications for biopsy, I'll go through all the screening services that we have and how that ends up into a biopsy. And then we'll look at the types of cervical biopsies, the types of biopsy that we get for cervical cancer. Then one of the things that I decided to bring on board is pre-analytics. What are these things that us as clinicians do that is going to improve our diagnostic capacities in the laboratory? So whatever is in black is what I'll really look on, because those are the fundamentals. Then on the analytics, I'll just look at something small on the diagnostics, on what we report. So something small, and hopefully everybody follows through. So on anatomy, if you look at this, we are looking at the cervix. So we need to know, where is the cervix? What is our target? So we need to know where is the location of the cervix, which is actually the lower narrow part of the uterus that connects to the vagina. It serves as a passageway for menstrual flow, sperm entry, and childbirth. And this cervix has an interesting anatomy because it has what we call the layers. If you look at your skin, that is what we call the epithelium. If you look at your palm, there is an epithelium on it. And if you look at your dorsal aspect of your hand, there is an epithelium. They look different. One is a bit lighter than the others, but they're still epithelium. It's only that there is a small difference. So that's the same thing that happens with the cervix. So in this, when we are looking at the cervix, the outer layer is called the ectocervix, which is usually a stratified squamous epithelium. Then we have the inner area. I don't know whether you can see my cursor. The inner area is called the endocervix, and it has a different epithelium, which we call the secreting columnar epithelium. Then we have a transformation zone. Now, the transformation zone is usually just between the ectocervix, which is this, the ectocervix, and this. So that area is the transformation zone. And if you look at this, this is even showing you a better picture on the same. And the transformation zone is very important because this is the zone where most cancer changes occur and develop. And that is why knowing the anatomy is very important, because when you're taking a pap smear, this is what we want. We want not only the os, the ectocervix, we also want not only the ectocervix, which is here, we also want you to go inside the os and get into the endocervical canal and into the transformation zone. Okay, now this picture, I know we've already gone through this before in the previous presentation, but it is very important to to always go through this whenever we are talking about HPV and we are talking about CA cervix. So this is just a small breather to just remind you of the previous two presentations, and not to over talk about it, but it is very important to know there are various things. There is the HPV infection, and there is the cervical intraepithelial dysplasia, or what we call the changes secondary to HPV. And if you look at this very importantly, there is the infectious viral particle before any changes, where you have a normal epithelium. Then later, you start forming what we call dysplasia. And this is when screening comes. The screening for using VIA and pap smear come in hand. But the HPV gets here at the beginning when the infection has started. So I won't talk so much about it, but I just wanted you to look at it, and so that we can move together. And the other thing is that HPV infection positive, if you get HPV infection positive, doesn't mean you have the dysplasia, doesn't mean you have the CA cervix. From infection to CA cervix takes between 10 to 20 years. So we have time to actually screen, and that is why we really insist on screening, so that we avoid this, the last part where it is called invasive. Okay, so what are our indications for cervical biopsies? So one of the indications for cervical biopsy is dependent on the mode of screening that we've used. So the most popular mode currently in our country is via VIA. And using VIA, after using the speculum, we get suspicious for cancer. A person can actually see there is actually a suspicious lesion. That patient needs to be sent for biopsy. The other one is positive via. You don't actually see the lesion physically, but when you put acetic acid, then you see a lesion like what is on your left of your screen, where this lesion is way larger and not eligible for ablation. I think last week we were taught about screen and treat. And when a lesion is more than where you can do thermal ablation, then these ones are the ones that are eligible for biopsies. Now we go to the second form of screening, which is the pap smear. If you look at the right of your presentation, we have conventional or liquid-based cytology, where we have different results. Whenever we do this, we would like to have a negative for intraepithelial lesion or malignancy, which we call NILIM. Then we have what is called ASCAS, and anything above ASCAS. So everything above ASCAS is what I have on my left. So we have low SIL, what we call low-grade squamous intraepithelial lesion, high grade, which is high SIL, and atypical squamous SH, or suspicious for adenocarcinoma. So when you go back to your algorithm, this algorithm, you'll find them in the early, in this book. Let me go back on this book, the National Cancer Screening and Early Diagnosis Guideline. So this book is also accessible through the NCCP website. So if I go too fast, don't worry, you have access to this this algorithm. So anything that is above ASCAS, which are these ones, then we go for colposcopy. And during colposcopy is when now we'll check, is the colposcopy positive? Is it negative? Is it suspicious for cancer? So that now you can know when to do biopsy and when to do LEAP. And all those to us, whether it's a colposcopic small biopsy, whether it's a LEAP, all those are biopsies in the laboratory aspect for pathologists. So for colposcopy, so the abnormal colposcopic findings after you've done VIA, after you've done pap smear, then you do colposcopy. So in abnormal colposcopic findings will be as follows: acetowhite epithelium again, abnormal vascular patterns, punctuation, mosaicism, Lugol's iodine negative areas, irregular surface patterns or friable lesion, and suspicious lesion, visible growth or irregularities on the cervix, persistent ulceration or erosion. For all this, we shall all do biopsies. Remember, I'm just saying biopsy. I didn't say actual the type of biopsy. So now let's go to what types of biopsies do you do so that we can have a diagnosis for you. So this one is dependent on what the specialist has seen. And we broadly categorize them as incisional biopsy or excisional biopsy. So incisional biopsy are just for diagnostic, excisional biopsy are diagnostic and treatment. Something like lip can be excisional biopsy, which can be, of course, removing the lesion plus treating. So these are the colposcopic, these are the incisional biopsies where you have punch biopsy, endocervical curettage, endometrial curettage. And then the excisional biopsies, we have hysterectomies, we have lip, and we have cone. So for these ones, it will depend on the grade and the presentation of the patient. If the patient has lesions that are going into the vaginal canal, then the doctor might, the gynecologist might choose to do a hysterectomy. Then if it is just within the cervix, then a lip and a cone biopsy can be done. And remember, this one's lip and cone can be a biopsy for diagnostic and also treatment. So once these biopsies have been gotten, what are the most critical things that we need to do to ensure that I, as a pathologist, can be able to give you a good report at the end of the day? And this is what we call in the laboratory, we call pre-analytics. And the pre-analytics for me today, I chose just 3 pre-analytics, and one of them is sample fixation. I can't, I don't know, I feel like this is one of the most important things. If there's anything that you get out of this presentation, please remember sample fixation. If the cone biopsy is taken, you do a very good job, everything, you take a hysterectomy, then we don't put the sample in formalin, 10 neutral buffered formalin, the ideal quantity, then we have done injustice for the patient. So because by the time the biopsy reaches us in the laboratory, it will have gone through what we call autolysis. In layman's word, itakuwa imeoza, and that's not what we want, because once it has undergone autolysis, then there is nothing much we can do. We won't even be able to give you the results. So for me, I think this slide is one of the most important. So take-home message is this. This is one of my first take-home messages. 10% neutral buffered formalin. If you don't have neutral buffered formalin, please just use 10% formalin. And the volume should be adequate. Then again, the other thing that we have a problem is labeling standards. That specimen bottle needs to be labeled and the request form needs to be labeled. We get a lot of samples that come to the laboratory. The specimen bottle, no name, no nothing. So we cannot be able to link the patient to the sample. So we don't know what to do. And now you have your patient there. Here we are, we have a sample we don't know. And remember, we don't just receive one sample. We receive 20 samples. Can you imagine 5 of those samples don't have a label? Then we cannot be able to say A is A or B is B. So this is one of the most important take-home messages for today. So again, also the specimen containers. I know we have a problem, but we need to improve on this one. We need a wide-mouthed container. Can you imagine putting a hysterectomy specimen into a small container like this? Once you squeeze a biopsy, when a biopsy is fresh, it is malleable. But when we start fixing it, it becomes hard. And when it is in a small space, you squeeze it. And once we do the processing, then we have what we call as crush artifact. And crush artifact also gives pathologists a lot of problems in trying to figure out, is this a crush artifact or is it something going on in the nucleus? Is it suspicious for malignancy? And that even wastes the time of us giving you back the report. So please, again, if you have a big specimen, look for a big specimen bottle so that we avoid crush artifacts and we avoid giving you results that are false, not because of anything else, but it's because of the pre-analytics that we're having issues with. So again, my take home, pre-analytics, sample fixation, labels, labeling standards, that's both on the sample bottle and the request form. Then we go to analytics. Now, once the specimen reaches the laboratory, if you look at it, we have to verify and document specimen details. And this is where we check whether there's formalin, whether we need to add more formalin, whether we'll have autolysis. And autolysis also gives us a problem, especially when later you want to come and ask for immunohistochemistry. Once the enzymes are gone, they are gone, then we'll have a very big problem trying to do our immunohistochemistry to figure out what's happening. Then, so that's when we do grossing, processing, sectioning, staining. So we won't go through all that, but I have a few photos to show you exactly what happens. So this is a hysterectomy specimen. And if you look at it, there is actually a large cancer on it. And this is what we don't want to receive. I know it is a pathology specimen, but because of what we've done, the HPV testing, the HPV vaccination, and the screening, both via HPV and CS and pap smear, we want to avoid receiving patients with such cervix, because now these ones are the ones that are leading to death, because it's a bit advanced. There are others which are even worse. It's a bit simpler. Then this is what we'd like to receive, cone and lip, because when we receive lip and cone, that tells me that we have been able to get this woman early. We have been able to remove the offending area. Not only is this a biopsy, it's also a treatment. If you look at it, why I say it's a treatment is because of this area at the edges, what we call margins. And when we gross, this is what we do. We cut them into small sections so that we can see everything and paint the margins. And then we put them into cassettes. So this is the part where I was talking about grossing. And then later we'll do a bit of processing. They'll be put into blocks, what we always call blocks or cassettes, which are paraffin embedded, and then they'll be microtomed, and later the slide is what is going to be given to the pathologist for reporting. The next part is just we need to store both the blocks and the slides in case we need to do further testing on the same blocks, or we need a second opinion on the same. So this is what happens in the laboratory. Now let us go back to diagnostics, back to the microscopic findings. So in the microscopic findings, what are the things that we find? Sometimes you've sent a sample, it was via positive, and the colpo biopsy comes back as normal, no significant abnormalities, inflammatory changes, e.g. cervicitis. And this is one of the common things I have noted. which is okay for me, because that means we are improving in our early detection. Cervicitis is one of the things that gives false positive in VIA. It will give an acetal white epithelium, so we'll end up getting a biopsy. Sometimes also in pap smear, these are the ones that end up as ASCAS, sometimes end up as locil, because for pap smear and VIA, what I usually say is it is usually user dependent. The more you look at things, the better you become. So the next is dysplasia, and that is what we are really interested in. And the dysplasia is classified as cervical intraepithelial neoplasia. So whenever you see our lip biopsy or our colpo biopsy, usually you'll have this as a diagnosis. It could be CIN1, which actually just talks about mild dysplasia, which is dysplasia on the lower third of the epithelium affected. You might have coelocytic changes. These coelocytic changes usually are what corresponds to the HPV infection. Now, that is what we call locil or CIN1. So in the pap smear, this is going to be called locil. And in the biopsy, it's CIN1, which we also call CIN1 or locil. So we have the second one is CIN2, which is moderate dysplasia, where the dysplasia is affecting 2/3 of the epithelium. I'll show you photomicrographs on the same. And this one is for making life easier, is also categorized as HSIL. And CIN3, which is severe dysplasia or the full length epithelial dysplasia, which is also known as carcinoma in situ. And when I say carcinoma in situ, that means it has not yet breached the basement membrane. Then we have what we do not want is the invasive cancer. This is the one that is now causing us more problems. But if we can get them in CIN1, CIN2, CIN3, then the lips and the cones will perfectly work, so long as the margins are negative. So on cervical microscopy, so what do we see? So this is what we see. Sometimes you'll hear when you see a report, you'll see the doctor writing normal basket weave squamous cell epithelium, and this is what we mean. It looks like a basket weave. It is normal. There is normal maturation. There's no issue. Then we have CIN2, where if you look between the normal and CIN1, you'll see the darkening. It's a bit darker on the lower third. And then you can also see what we call coelocytic changes, where there is a very dark nucleus within a small space. That is not normal. If you look on the normal one, the nucleus are very, very tiny. And the maturation is from base to top, where they're becoming tinier as we go to the top. But if you look at CIN1, there is a problem. So that is now when we start calling it dysplasia. Then CIN2, it's getting worse. You see, even the cells are much larger, and it's more, what I call it, more purple, darkly staining. That is what we call hyperchromasia. And then the cells don't look the same size. You have cells that are different sizes. That's what we call differently sized cells. Then on the third one, it is the full length. But if you notice all the three, the lower part, I don't know whether you can see my cursor. This is called the basement membrane. The basement membrane is intact. So the third one, that is what we call CIN3, and that's so these are precancer. If we do nothing on CIN1, CIN2, CIN3, there is a percentage of people who will progress to cancer, and that is why we need to do more in screening so that we can get them early and remove these offending cells so that we don't progress to cancer. So currently, all these are dysplasia, with CIN3 being carcinoma in situ. So CIN3 and invasive carcinoma, if you look at the two, they look different. CIN3, the offending cells are well placed. It's like there is a gate that they have not crossed. So you'll see this area that is the actual dysplasia, what we call cervical cancer in situ, but this area is okay. So the basement membrane is protecting, has shielded the rest of the ectocervix from the cancer. So this is what we call cervical cancer in the CIN3 or carcinoma in situ. If you look on your right, this is what we don't want. We don't want these cells to break through the basement membrane and invade. And we all know carcinoma, when we say something is malignant, it's when it has started spreading. And this photomicrograph actually shows it well. There is stromal invasion. So this is what we don't want. And if you look at this one has already gone into invasion. If you look at this, even without looking at it microscopically, we have already seen we have invaded into the endocervix. Not only are we not seeing the ectocervix well, we are seeing it has gone through the endocervix, and this is what we want to not have. So that is what a carcinoma in situ is. These are what is called dysplasia, pre-malignant lesion, and then this is the invasive carcinoma. So thank you very much. Just before we finish, this is another one that I wanted to look at, the regression. Usually CIN1, 49% will regress, 35% will persist. And it is this persistence, this 35%, 32%, and 56% that we need to treat. And that is why we tend to treat a bit aggressively, and to avoid going into progression into invasive cancer. So for me, I'd like to thank you very much for listening to me today. Any questions you can put in the chat box, and I'll be happy to answer your questions.
Thank you so much, Dr. Mudua, for that very insightful presentation. Now, I'm sure we've seen clearly how to accurately diagnose, and even the take-home message that she's clearly elaborated on how to do the pre-analytics, that is sample handling, so that the pathologist can get it while it's so fresh. And also thank you for reminding us about the anatomy. You know, we're in the era where we're talking about the self-sample collection. It's important that our people know how to do or where to get that sample from. We can use the reactions chat box to give our flowers for that insightful presentation. And also let us utilize the question and answer session. Thereafter, we'll have a session where we will discuss the various questions that are going to emanate. Now, I'm also going to introduce our second speaker, who is going to talk to us about the evidence-based treatment options of cervical cancer. She has a very rich CV. Dr. Afrin Fatma Shavi. She's a gynecologic oncologist dedicated to improving cancer outcomes for women in low-resource settings across Africa. She has extensive clinical experience working both in Kenya and Malawi, and she combines surgical expertise in research, leadership, and health system strengthening. Currently, she's practicing at the Nairobi West Hospital, where she supports cervical cancer, cervical and ovarian cancer treatment. Way beyond that, she's committed to research and capacity building. She was selected, with that respect, she was selected for the 2025 ASCO and IOTIC International Clinical Research Scholars Program, a prestigious initiative advancing early career African investigators. She is also a recipient of the FIGO Shin Tu Su Fellowship Program, which supports advanced global training in gynecologic oncology. Additionally, she contributes to her expertise to the Medicine Sans Frontiers, I think an organization that we all know, where she supports strengthening of cancer care in humanitarian settings. Dr. Ephraim, if you can hear me, kindly unmute and take over the presentation. Karibu sana.
Thank you so much. Thank you, Solomon, for the very nice introduction. So good afternoon, everyone. Today I'm going to quickly take you, I think we are really pressed on time, so I'll try to be as brief and as succinct as possible. However, let's look at the current management, both the surgical and
Kindly, if you can take 20 minutes, I'll appreciate.
Sure. Are you able to see my slides?
Yes, it's visible.
Okay, then I don't know. I unfortunately can't see them from my end. All right, so let's before we begin, I'd just like to give you the statistics. I know our previous speaker did mention. So currently in Kenya, the statistics are as such. From previously, the Global Can 2020, we have had an increase in the deaths related to cervical cancer. Currently, we see 9 women every single day that die from cervical cancer. Previously, there were around 8 women. So mortality is the #1 cause of deaths amongst women in Kenya. That is cervical cancer. Globally, of course, we also know that every 2 minutes a woman dies from this cancer. And yet, as my previous speaker mentioned, this is a highly preventable cancer. No woman should die from here. So this is where we globally stand in terms of statistics. Then looking at the staging, cervical cancer basically is previously or historically, we were just staging it clinically and using some very baseline investigations to support the staging. However, in 2018, FIGO revised this to allow both clinical, radiological, and integration of the pathological finding to assign a stage. So based on this, we have in the new 2018 guidelines, what was incorporated was the stage 1B was broken down into 1B1, 1B2, and 1B3 based on the size of the cancer. So anywhere between 1B2, the cancer is basically can be operated. 1B3 is cervical cancer that is essentially confined to the cervix, but it's more than 4 centimeters. So we would look at why this is important and why I've used this particular cutoff. Additionally, in addition to this, another thing that was integrated was the nodal metastases. So previously, before 2018, that is up to 2008, 2009, the staging did not include any integration of nodal metastases. But now we do both pelvic, which are the regional lymph nodes, and the para-aortics. So this confers a higher stages. And basically, why do we stage is mainly to do with prognosis, and broadly, you can also base some treatments, but generally this is to prognosticate the cancers. This is the current staging, which hasn't been revised, and currently even last year during the 2025, this was essentially the same. Now, one thing we commonly mistake is what is the difference between cervical cancer 4A and cervical cancer 4B. So basically 4A, I think this is where most of us mistake and categorize it as 4A when we don't have mucosal involvement. So this is very, very important. 4A is only when the tumor has actually spread to the mucosa. A bullous edema, basically you would see this on imaging, is not categorized as 4A. So when you see the tumor has spread into the into the bladder mucosa or the rectal mucosa. Now, this is where you would say that this cancer is a stage 4A. Otherwise, to the walls, whether it's the rectal wall or the vaginal wall, still puts it as a stage 3, basically. So I think this is something we all need to note. I think we've seen this. And why I'm saying this is because, again, the outcomes, the prognosis becomes the prognosis for stage 3 is basically 5-year survivals range from 30 to 40 as compared to 4A, 4B, where survival rates are 15 to 10%. So that is the relevance of basically staging and what we can use for staging. We can use imaging modalities. such as CT scans, MRIs, or currently, yes, we do have availability of PET scans. However, one of the main things, or one of the things that I would like to point out is PET scans can be used, but again, we need to know there's a high false positive rate, particularly given our population. We have quite a high number of women who are HIV infected, and given the HIV infected status would give, PET scans basically work by lighting up. So even any inflammatory process that is will light up. So there is quite a high rate of false positives. So when we are staging our patients, it's important that we take that into consideration. However, yes, currently we can use, and many guidelines, that is the NCCN or the ESCO, the ESMO guidelines, all support PET scans can be used for staging. For local staging, for cancers that you would like to operate, these are cancers that you want to see whether the parametry is involved. Because again, when there's a parametrial involvement, it actually renders the case inoperable. So you will not operate on a case which has obvious parametrial involvement, or even parametrial involvement that is picked up on MRIs. So MRI is the best modality for local staging. And this is why I say for local staging, because when you're discussing, or when you're planning your treatment modality, you need to see if this is an ideal candidate for surgical treatment. And that is where it will help you give you appropriate size for the tumor and whether parametry is involved or not. Now, for metastatic workup, if you don't have access to CT scans, then, if you don't have to CT, PET CTs rather, then you can use CT abdomen pelvis. Those have a higher sensitivity to detect nodal metastases as compared to MRIs. Now, the other question is, most of our county hospitals, county referral hospitals rather, the ones which have MRIs are usually 0.3 Teslas. And now why I emphasize on this is because the 0.3 Tesla MRIs are not your ideal MRIs to check for parametrial involvement. They're not very good for pelvic or for to check even characterization of masses of the ovaries. They're not your ideal. So you'd want an MRI machine that is at least 1.5 Tesla and above. Now, coming to treatment modalities. So again, I would like to break down the cancer stage here. So we what is termed as early cervical cancer. So basically, early cervical cancer would be disease that is entirely confined to the cervix. This can be in the form of microscopy or even visible tumor. And this can range anywhere from stage 1A up to 1B2. Now, when we look at 1A, what is basically 1A? 1A is further divided into 1A1 and 1A2. Now, the relevance of this is basically 1A1 or 1A2 are mainly microscopic diseases. So their dimensions are less than 3 millimeters, depth of stromal involvement, that is stage 1A1, and 1A2 is more than 3 up to 5 millimeters. And then anything between 5 millimeters and up to 2 centimeters is a stage that 1B1, and 1B2 is from a disease or a lesion that you can see that measures 2 centimeters up to 4 centimeters. So this is your cutoff actually for surgical treatment. And now again, I would like to emphasize the different types of surgical modalities that you can take, specifically for women who have a desire to preserve fertility. So these can include hysterectomies, which can be extrafacial hysterectomies, modified radical or radical hysterectomies. I'll not really go into the depth of what all these hysterectomies mean and how extensive the dissection is, but basically even hysterectomies vary, and this will depend on your histological type, on the stage, and what is the fertility desires of the women. The other thing is, of course, where you don't have the surgical expertise, the other option can be radiotherapy with or without chemotherapy. The outcomes are pretty much the same. They have the same outcomes. However, of note is that radiotherapy usually would be associated with more morbidities. We would generally the patients who we can operate, we would want to operate on them. However, there are specific groups of patients, say the elderly patients or patients with multiple comorbidities, very obese patients, or patients with poor functional status. These are patients you would want to consider a more conservative approach, such as radiotherapy, as compared to the surgical treatment, because surgical treatment has its own nuances and there are a lot of complications with even the basic surgeries. So you have to have your ideal candidates, and you can offer to a specific group specific treatments such as chemorads, even for early stage. Then the quality of life, as I mentioned, is better with surgical as compared to the primary radiotherapy if you're offering it for early stage. Additionally, once you do radiation, if you're not going to transpose the ovaries, you have a high, the amount of radiation that is needed is even as little as 10 grays to sterilize the woman. So yes, this is one of the fields, one of the things that you would want to consider when you're opting for radiation, and it can induce menopause in this group of women. Then this is the classification, as I mentioned earlier on. We're not going to go into the very detail of the classification, but basically extrafascial hysterectomy is just a simple hysterectomy. When we go to type B1, B2, these are more radical, and then C1s and C2s are extremely radical, where we want to remove everything and we want to take a wider parametrial, and even when we're doing our resections, we go to the base of the bladder. Some of these C1, C2s, C1 is basically nerve sparing because you want to take a wider margin when you're resecting your parametria, and this can be your anterior, dorsal, or lateral parametrias. So yes, in certain cases, you would want to do a nerve sparing, and certain cases you go on to now not do a nerve sparing, which are the C2s. And then we have the Ds. So microinvasive cancers, these are tumors that are less than 3 millimeters with the depth of, so these patients basically without lymphovascular invasion. I'll not go into the very details so as not to confuse most of you. So microinvasive cancer, stage 1A1, where you do not have lymphovascular space invasion. So basically, these are the candidates that can be offered just hysterectomy alone, and that is sufficient. Or they can, if they choose to do so, fertility sparing, such as cones or simple trachelectomies. And why I say this is because patients with who are stage 1A1s with no lymphovascular space invasion, their lymph node metastases is very low. The rates are vary between 0.1 to 0.4, basically they're less than 1%. So these are the candidates you can actually safely eliminate pelvic lymphadenectomy. However, now when I talk about pelvic lymphadenectomy, again, this means removal. There are studies that talk about sentinel lymph nodes. We haven't fully embraced sentinel lymph node for cervical cancer. We have ongoing studies such as the Cervical studies. We await their results to really completely and comprehensively allow us to safely do sentinel lymph node instead of doing a systematic pelvic lymphadenectomy. So these are the candidates you can offer this, and they don't need pelvic lymph node dissection. However, the other thing is patients who do have lymphovascular invasion, their risk of nodal metastases, and nodal metastases can be microscopic, So these patients would have a higher risk of nodal metastasis, and these are the candidates you would actually want to now offer pelvic lymphadenectomy so you can do a comprehensive staging. Now, this brings me to a very important point that I would like to highlight. So patients, how do we diagnose microscopic disease? This is another thing I think we often see as gynecologists. We have a patient, someone says, I haven't seen a lesion, and this is automatically 1A1 after the biopsy. But no, that's not the case. Actually, for you to make a diagnosis of a microscopic tumor, you need to do a cone or a leap. And this is what will direct your management. It is mandatory for you to do that. But in order for you to do that, you need to do a cone or a leap. And once the corn or the leaf specimen has come back, when you're taking these specimens, it's very, very important for you to tag the specimen at, say, 12 o'clock. So this helps the pathologist to know where the tumor is. And you can also, when you're doing, again, I'll reflect a little bit back on our pathology forms. When we're filling pathologies, make sure you've said, this is where we've found the tumor, this is what is visible, history, findings, all that is very important. So once we have a corn, the corn will tell us, or the leaf specimen will tell us whether this is a 1B1, 1A1 or higher stage. So if it is in essence 1A1, then you can go ahead and do the hysterectomy. However, if you have a 1A1 and your margins are positive, now such a case again, it's, it makes you think that's definitely not a 1A1. So you would want to repeat a cornization or a leap to again see the depth. Now, if you're on your repeat corn or leap, you still have positive margins, that patient actually warrants a more radical surgery. And this can be in the form of a radical trachelectomy, depending on what her fertility desires are, or a radical hysterectomy. So these are some of the things we need to consider. Yes, we do have several trials that have come out, and I'll mention two main trials which have actually changed practice globally. However, and then I'll also just like to just point out what are the implications of these trials and how can we adopt these trials in our setup. So now we need to know something very, very important, and this is why, oh, yes, we can offer conservative surgeries such as simple hysterectomies or just corns, but we need to know our ideal candidates, who are the candidates where we want to offer these surgeries. So the disease, these patients, based on the concept trial and the shape trial, the patient, the histology or the histological type should be squamous cell or adenocarcinoma. What you would not, or the stage should be stage 1, A1, 1A2, and 1B1 tumors with less than 2 centimeters. And now this context, this criteria, the limited stromal invasion or 10 millimeters of stromal invasion on a corn or leaf, or 50% of whatever you see, a stromal invasion on MRI, or at least 3 millimeters of intact stroma that is not involved, this is what you need to have. And the other important thing is no evidence of lymph node metastases on pre-op imaging. Now, like we discussed, what is the relevance of you doing a metastatic workup? What's the relevance of you doing a PET CT? You need to do that so that you can ascertain whether this is a candidate that would benefit from one treatment over the other treatment. So yes, we can do hysterectomies. Yes, we can do more conservative surgeries, but we need to be very specific about these. Otherwise, you are subjecting the patients to a higher recurrence when we don't have these. And then again, the limitations in terms of pathology. Currently, yes, we do have pathologists, but there's a lot of issues with gyno pathologies globally, and these are not as simple as they seem. They can be complex. And you see, we have pathology reports from some labs, they're not really accredited, etc, etc. So when you're determining whether this is a surgical candidate or not, it's very important to see that you have a good pathologist who has reported. If there's something you don't, you're not able to find out, please communicate with your pathologist. It's very, very important, I think, in oncology. So all patients with, then patients who are 1A2s and 1B1s or 1B2s, you can go ahead and offer them a little more radical surgeries, particularly the 1B1s and 1B2s. And for 1B2s, we would ideally, in fact, if you look at the European countries, some of the countries don't even do surgical treatments for 1B2. And the reason for them not doing surgical treatments for those patients are because the radicality of surgeries. So 1B2s actually require very, very radical surgeries, and they don't, you need to do basically a type C1 or C2 radical hysterectomy in order for you to remove what is required to get good margins. And if you're not able to get good margins, or you have smaller margins of less than 3 millimeters, you are actually leaving the patient open for a faster recurrence. So such a patient, actually, if you don't have, again, I would come back to this, if the surgical expertise is not there, then kindly send these patients for radiation treatment, because the outcomes are pretty much the same. And you want to make sure that whatever treatment you're offering your patients has a good benefit. And the other thing is, patients who are early stages, the 1As and 1Bs, have pretty much very good survival rates. So we need to keep that in mind. So this was the outcome of the SHAPE trial. They said that when we have conservative surgeries pretty much have same survival rates as those we were doing radical surgery. So yes, you can do conservative surgeries in a specific group of people, particularly the lower, that is the low risk. And then the other thing I think a lot of us would like to know is the role of minimal invasive surgeries. So yes, minimal invasive surgeries have been adopted. Even in the SHAPE trial, there were patients who underwent. But one of the things we need to know is most of these have been done in a study setting. We don't have the ideal settings to adopt fully that minimal invasive surgery is safe. As per the LAC trial, I know the LAC trial results were released in 2019, but we've had several debates. Until we have robust studies showing that there are no adverse outcomes with minimal invasive, the current practice tends it that these patients actually require open surgeries and not minimal invasive surgeries. Yes, there are ongoing trials, the ROC and RAC trial. I think a lot of us are eagerly waiting for the results of those trials to actually tell us whether it's safe or not. But until then, open surgeries are what is recommended for cervical cancer. And this will combine with pelvic lymph node dissection. And you can do that either sentinel or systemic pelvic lymph node dissections where resources allow. So that is that. And key message for the early stages to all clinicians is, please, patient selection is key to proper outcomes. I will not go into the fertility preservation, but just briefly touching on that, there's a specific criteria for patients who desire fertility, but one of the criteria is these women should be less than 40 years. Currently, given the dynamics across the world, women are delaying childbearing. So 40 years, sometimes in some settings, they would even push the age up to 45 years. However, this is entirely based on the fertility potential. The other thing is there's a specific criteria for which women you can offer fertility sparing. So make sure these women have a lesion of less than or equal to 2 centimeters. They have a low risk histology of squamous cell carcinoma, adenocarcinomas, or adenosquamous, negative lymph nodes, and they have a tumor-free margin of 5 millimeters and more, meaning on your imaging, at least you see the tumor, you can get a good margin. So in these women, yes, you can offer. However, for women who have tumors more than 4 centimeters, we don't have any robust data to show that fertility sparing is safe in these women. So no, we don't offer fertility sparing. Again, before you do any of these in some of these fertility sparing, you would need to do nodal metastases. You would need to combine it with a nodal dissection. So yes, while you would be offering your cones, the principles are pretty much the same. You would still offer your cone or your trachelectomy, but patients who are 1A, 2 and above, you would want to do nodal dissection in this, and that can be done laparoscopically as you're doing your fertility sparing, such as cone or simple trachelectomies. Or in some patients also. In terms of oncological outcomes, we don't have differences in oncological outcomes. However, there's some implications of some of these procedures. We do know that the rates of miscarriages and cervical stenosis are slightly higher in these women. Insufficiency is also preterm labor. And sometimes because of the complete stenosis, we have seen fertility rates, and these can vary among women from 14 to 45%. So this is what we were talking about. This is, again, very important post-treatment follow-up. I think this one we'll cover in the last slide, so I'll not go through this. Then we've already talked about minimal invasive and the LAC trial, which was and is a landmark trial until now. Let's wait for the final results of the RAC and ROC. So yes, after you've offered your cervical cancer treatment, surgical treatment, your treatment is not yet over. And hence your patients these patients are with you for a long time, because once you get your histology, there's specific risk factors you need to look out for to determine whether these patients would warrant any additional treatment, such as in the form of radiotherapy, in the form of chemorads. So these are based on two major trials, actually three, the Delgado study and then the Peters and Sadley's criteria. These were GOG studies, actually, but they were back then in 1990. I think the Peters was in 1999, and the Sadley's was a study that was the GOG trial that was done in 2000, and I think 2000. So basically, these studies, we had criteria known as the high risk. And why we call as high risk, because these patients who have any of these risk factors, say now you've got your histology and the patient has a positive surgical margin, or she is pathologically confirmed pelvic lymph nodes, or there's involvement of parametria. Basically, these are patients who have a 50% risk of recurrence and 40% risk of death. So these patients definitely would require adjuvant chemoradiation. Now, depending on whether the vaginal margins are positive or negative, then we can determine whether they would require brachytherapy or not. And then we have the intermediate criteria, which you need two of these criteria to determine whether they require additional chemorads. Just briefly touching on locally advanced cervical cancer. So basically, locally advanced cervical cancer is cervical cancer that is stage 1B2, meaning 1B3, that is tumor that is more than 4 centimeters up to 4A. Without distant metastasis. So these candidates can benefit, and the treatment for these candidates is basically chemoradiation. So this chemoradiation can be in the form of weekly concurrent chemo with RADs, which would be external beam. We have better, more precise modalities with less side effects, such as VMART or stereotactic body radiotherapy. We combine this with intracavitary brachytherapy to deliver the maximum dose. And the treatment ideally should be completed in 56 days. That's approximately 8 weeks. Then, yes, we have new modalities that allow, from the Keynote A18 study, demonstrated that patients who are stage 3 and above had a better survival with incorporation of pembro, regardless of the PD-L1 receptor status. Role of induction chemo. I think this is a question we keep on asking. What did the Interlace trial? Basically, this was a trial that demonstrated there was a benefit of giving chemotherapy before chemorads. And the survival benefit was 9% and 10%. And people across the globe are embracing this, particularly for slightly bulkier tumors in our settings. Of course, we don't give it as per the exact protocol of the Interlace trial, but we do give similar sequential chemo, and we are seeing good outcomes. We don't have local data to say that this is it, but hopefully we will generate some. The other important question is there a role for hysterectomy after chemorads? We do have evidence that does not support hysterectomy after chemorads. In fact, if patients have had a good response, we don't need to do anything, just follow up. Then another important question is role for systemic chemotherapy. And this was again demonstrated in a very big trial, the Outback trial. And this trial showed that there was no benefit of adjuvant chemotherapy, systemic chemotherapy after primary chemorads. There was no survival benefit, basically. So no, this is not what is currently embraced across the globe. And these are this. For metastatic disease, this will depend on your treatment goals and the extent. You can do chemo or you can do palliative radio. Additionally, this can be combined with immunotherapy, which can be checkpoint inhibitors or angiogenesis inhibitors, such as beva or pembro. Again, this will depend on what your goals are and the financial implications on all these treatments on the patients. So financial toxicity and distress is a very, very important thing that we need to discuss due to the implications on the quality of life. Follow-up treatment. Finally, we come to the last slide, which is the follow-up treatment after you have, follow-up after treatment. So basically these patients, as I mentioned, they're your patients and they will be there with you for many, many years to come. So primarily follow-up you do through history and physical examination. And then we come to, you need to do a comprehensive exam and see what the symptoms are. And then based on that symptomology and your physical exam, you can then order imaging modalities. In terms of pap smears, so I've seen this a lot, I've seen patients coming for pap smears after chemoreds. No, we do not perform pap smears because your vaginal mucosas, the cells in your vaginal mucosa will be altered. And so you would not get an appropriate or a good result. So we don't do cytology. However, you can do colposcopies in such women who've undergone chemoreds. For women who've undergone surgical treatment, for these women, you would need to do cytology and colposcopy depending on your findings. Again, routinely, we don't do CT scans and MRIs. I see a lot of patients every 3 months, they're coming for CTs and MRIs. Really, studies have shown there's really no benefit. However, in patients who are at a high risk of recurrence, what has been and currently is recommended across many guidelines is whole body PET CT scans. Post-treatment, that this can be offered between 3 to 6 months, not earlier, because before that, when you're doing, you remember these patients have had chemoreds, they've got a lot of inflammation that is going on. So you're going to have findings that are not really recurrence findings, and you would then, some people or some of us would feel mandated to treat these. So you need to wait. And then once it has confirmed recurrence, you need to biopsy and see, is this a residual tumor, is this a recurrence, and then you treat accordingly. So the essence of follow-up basically is for you to pick up any recurrence earlier and treat this accordingly. There are specific people who would actually benefit from surgical treatment in terms of recurrence. And then the duration, so for the first 3 years, because the recurrence rates are pretty high, we would want to put them at intervals of 3 months for the first 2 years, 3 to 4, and then every 6 monthly for the next 3 years. So after that, you can say yes, and if there's no recurrence, yes, my patient is now treated of cervical cancer. So I think with this, I come to my last slide. In terms of prognostic factors that affect survival, this will definitely depend on the stage. As I mentioned earlier, stage 1 to have survival rates that vary between 80 to 90%. Nodal status substantially decreases your survival to as low as 30%. Tumor volume, depth of cervical stromal invasion, the histological type, and LVI. These are other risk factors that would impact survival, but some of these risk factors are not independently associated with survival. They're a mixture of other risk factors that would constitute or contribute to the survival benefit. So this is the end of my presentation, and this is our key message. Collaboration is very important. This collaboration needs to be between gynecologists, and other oncologists, rad-oncs, and we need to have a comprehensive understanding of the disease so that we can offer our women the best treatments. Thank you, and better outcomes. Thank you. Sorry, I think that was really fast. It's just that I had too much and very short time to present that.
Sure. Thank you so much, Dr. Efren. That was indeed a very extensive presentation. I can tell from the type of from the comments that are coming in from the participants, most of them are saying that it's indeed very informative. One thing that I'm learning from this is that it's not just about cervical cancer treatment. It's about linking stages to treatment. It's about evidence for treatment. Thank you so much. And for the presenters that have just done their presentations, like Dr. Efren, Dr. Mutubua, you can check on the Q&A and you can be engaging our participants from the various questions that are coming. I can see we have a good number of participants, almost 900, and I'd like to encourage you to keep on. We still have one more presentation that is coming up. And at this time, I want to introduce our next presenter, Dr. Collins Masolo. Now, Dr. Collins Masolo, the good thing with him is that he's bringing in a clinical and a policy perspectives when it comes to cervical cancer treatment. Dr. Masolo is a senior clinical and radiation oncologist who, for the longest time, has worked at the Kenyatta National Hospital, but currently working at the ministry at the National Cancer Control Program, where it supports Pillar 3. So Pillar 3, it's about treatment and multidisciplinary clinical initiatives. So he holds a master's in radiation oncology from the University of Nairobi and a bachelor's in medicine and surgery from Moi University. He is an active member of KESHO, CROSC, and the Kenya Medical Association. Without any further delay, Dr. Masolo, kindly take up the stage and put up your presentation.
Right. Good afternoon. I don't know if you can see my screen. And if you can actually hear me. All right, thank you. So I think I'll start I'm actually going to present the last aspect of the presentation, basically looking at the treatment-related complications that may occur as a result of treatment of cervical cancer. And at the end of this, we'll recognize common complications. Usually they will be by stage, the necessary clinical assessment that is required, and mitigating measures that may be taken. Of importance, we'll also mention the integration of supportive and palliative care in these patients. Mostly after treatment, these patients go into survival, and after survival, they usually encounter various aspects of disease or comorbidities that need to be addressed in the post-treatment era. So just a recap of what has been shared by my colleague. By and large, for early stage cervical cancer, most patients are usually treated with either radical surgery, either hysterectomy, depending on which type, either with lymphadenectomy, plus or minus radiotherapy, depending on the risk stratification. Chemotherapy may also be used based on the Peters criteria. Trachelectomy, fertility sparing may also be employed. For locally advanced disease, and this represents the majority of the patients in our setup. About almost 18% of our patients usually present with stage 3 and above, or rather locally advanced disease, and the main treatment is usually concurrent chemoradiation, in which external beam radiotherapy is given up to around probably 45 to 50 gray, and to the primary tumor, the tumor is boosted to up to between 85 and 90, depending on the volume. Overall, you'll see there's actually a large dose of radiation that is given. The techniques are varied. You may have 2D, 3D conformal, IMRT, or even more advanced techniques like volumetric arc therapy. Most of the side effects caused that occur in radiotherapy are by and large can be mitigated through meticulous and well-optimized treatment planning. For patients, you noticed most of the patients are now also getting neoadjuvant chemo. Some will get concurrent chemotherapy, and the ones who have metastatic disease, we may get systemic chemotherapy, plus or minus immunotherapy or targeted therapy. Palliative radio may also be given for symptom control, such as pain or bleeding. So in the early stage, most of the predominant complications tend to be surgical related. There will be hemorrhage, hematomas, mostly attended by hypotension, tachycardia, drop in HB. There may be the risk of infection with the characteristic fever, local tenderness, with wound erythema. There may also be damage to the adjacent organs, such as the ureter, where there may be injury or obstruction, leading to further complications such as hydronephrosis, flank pain, and also posing a risk in terms of acute kidney injury. There may be injury to the bladder, which may be manifested by dysuria, hematuria, and urinary leakage. There may be subacute or long-term complication to the surgery, such as urinary dysfunction in the form of incontinence. There may be urgency from autonomic nerve injury. There may be pelvic floor dysfunction, especially if the surgery is quite radical, attended by chronic pain. There may be urinary retention. Lymphoedema, you notice that in some cases, the lymphadenectomy may be done. Some patients may end up actually getting also adjuvant radiotherapy, all combined to increase the risk of lymphoedema, either to the pelvis or to the lymph nodes. Sexual dysfunction is a common thing that usually occur, and it's one of those things that is usually missed. Most patients are usually shy to bring it up, but it has quite a lot of mobility, not just to the patient, but to the social structure around the patient. Uh, so for early stage, usually the focus when clinical assessment is usually for a surgery is a good history, focus on symptom timing, and focus physical examination, abdominal pelvic examination, speculum, the usual CBCs, renal function, inflammatory markers if there's infection. Imaging may also be of importance, ultrasound or CT scan or MRI, depending on what is suspected. Cystoscopy, ureteroscopy, as indicated from the history, if there's suspicion of damage to the bladder or to the ureters. In early stages, the principles are usually, if you suspect that there's been an immediate complication, the principles involve prompt surgical repair. If there's hemorrhage, resuscitation, control of the hemorrhage. If transfusion is required, that has to be done. And then exploration if there are persistent symptoms. The other thing that needs to be considered is antibiotics. If there's infection, if there's an abscess, drainage as indicated by the clinical findings. In the rehabilitation set, if there's pelvic floor damage, there'll be need for pelvic floor exercises, scheduled voiding, intermittent catheterization if there's retention. Lymphoedema therapy will involve things like compression therapy and physiotherapy. Sexual function dysfunction is a big topic, and I'll cover it even later on. That will involve counseling, use of lubricants, pelvic floor exercises. By and large, the next thing to focus on is for most of our patients, 88%, who usually present with local advanced disease. Most of these, they'll end up getting radiotherapy. And most of the side effects are usually related to the treatment that they're given, and by and large can be mitigated. There are several risk factors that can actually potentiate or worsen these side effects. For patient-related, there are things like comorbidity, such as if the patient is immunosuppressed, if they have any diabetes or any arterial peripheral vascular disease. The nutritional status of the patient is poor, will also worsen the symptoms. If they're old, fragile, have a high BMI, this one usually has actually a significant effect when you're giving radio. Basically, patients who are obese and have a high BMI may have skin folds in the area that is being treated. Skin folds usually have an effect of bringing the dose of the fallout of the treatment that's being given by radiation to the skin.
Almost dropped my so
Yeah.
yes,
Yes.
please.
All right. All right, let me continue then. Yeah. So, what's in the effect of the radiation on the skin? So most patients will have symptoms related to the radiation, depending on the tissues that the radiation goes through. First and foremost is usually the skin or the epithelial structures. And then, of course, you have the mucosa in the rectum, in the vagina. We'll talk a little bit more on dermatitis because it's a significant thing that comes up during treatment of patients. And it's usually not a matter of if, but when it occurs and the severity. The other thing that usually comes out is this cystitis, which is attended by dysuria, urgency, and frequency. Sometimes you may actually have frank hematuria presenting in some of these patients. There may be GI-related symptoms, especially for patients who have had surgery before. These are patients who, once they've had surgery, you remove the uterus and you treat. You usually find the small bowels actually lapsing partially into the pelvic area and coming into the radiation field. And the treatment usually will cause certain symptoms: cramping, diarrhea, nausea, fatigue. Some may even have almost full-blown like systemic symptoms, what the so-called radiation syndrome. To the rectum, because they may have also proctitis, which may be acute or even chronic. The pelvis being radiated is a foci of hematopoiesis, and some of the patients might get an element of myelosuppression, mostly from the radiation and also from the chemo. Some will have gotten adjuvant chemo, they may be getting concurrent chemo or maybe on systemic chemo, and may have either neutropenia, low HB, or anemia, especially if they're getting concurrent chemo. Fatigue and nausea is a common thing due to the radiation and also from the chemo. Saturation is one of the side effects that usually occurs very early in the treatment. Once you have given doses in excess of 10 gray, that's usually about a week. Chances of sterilizing women and knocking them into sterility and also menopause are really high, that particular point with attendant side effects. So I'll just probably bring a bit of focus on radiation-induced dermatitis. It's a fairly common thing that usually occurs in patients and can be quite debilitating and cause a lot of discomfort. In the acute phase, it may present with various symptoms and is graded according to the severity. So grade 1 usually they'll present with just fair erythema. In the dark skin, it may appear with like hyperpigmentation, dry discoloration, where the skin looks dry and is flaking off. As the grade worsens, you may end up with a moderate or brisk erythema. You may also have some bit of moist discoloration, where there's a bit of oozing, confined mostly to skin folds and creases. There may be moderate swelling around the skin. By the time you get into grade 3, you have moist discoloration in areas other than the skin folds and creases. Some of the patches usually confluent to make bigger patches that are wet and oozing. Bleeding may occur or following minor trauma or abrasion. By grade 4, you're having life-threatening consequences where you have now skin necrosis occurring in the full thickness of the dermis with ulceration. There may be spontaneous bleeding from the involved site. Most of the time, this necessitates the stoppage of the treatment and enrollment of the surgical team in the management. Is treated almost as a grade 3 burn. Skin graft may be indicated. We don't usually want to get to grade 4 because that is characterized by death. This is just a picture, just demonstrating some of the. Let me see if I can get a laser pointer. Just demonstrating just the grading. As you can see, this is in white skin, but in dark skins, this might appear more like a darkening, and you might see the skin very flaking in areas. This is in the head and neck region, but the same would happen in the pelvic region. By grade 2, you have the moist discoloration occurring. And by grade 3, it becomes confluent in areas beyond even the folds. And if it's in the pelvic region, you may have now almost extending to the thighs and the pubis. But in grade 2, you may mostly see it around the inguinal clefts. In obese patients, because they usually have a bit of the fat pad from the abdomen overlapping the pubis moniz, it creates what is known as a bolus effect during radiation. It brings the dose of the treatment from the pelvis right up to the skin and worsens the effect of the radiation at the skin. In grade 4 is where you have now frank bleeding and ulceration, and this one is usually the treatment has to be stopped and remedial measures taken. So these are basically the measures that can be taken to ameliorate the different grades. In the first, basically, is to moisturize by applying unscented hypoallergenic creams. That's in grade 1, where there's just dryness and flaking, such as aqueous cream. Steroids, topical steroids may also be used at this particular stage. When you start having now the development of moist discoloration, you may continue using the non-scented emollients. Aloe vera and hyaluronic acid creams may also be used to offer relief. And at this particular point, if there are any breakages in the skin, you may want to employ Nadiaran dressing or hydrocolloid hydrogel dressings. This particular point, there are also silicone-based gels that are coming into effect that can also be used at this particular point. It's always good to check for infection and give either topical antimicrobial agents or systemic antibiotics. Most patients will be experiencing pain, and it will be good to actually give them some form of pain analgesia. That's why it's good to involve the palliative team right at the beginning of the treatment. At grade 3, where you have ulcerations, you may have to involve a very good wound dressing team from the surgical unit. They may use things like silicone-based dressings, hydrocolloids, support healing and eliminate exudates, monitor for infection, and treat them as they arise and control the pain. And for grade 4, you may have to actually stop the treatment. Consult the radiation oncologist, dermatologist, the plastic surgeon, wound care specialist, stop the treatment. This is because of this is occurring due to necrosis and ulceration. A surgical intervention is required. If not, it is life-threatening and can lead to grade 5 with death. And then you also have locally advanced, you also have like toxicities that may occur. These are actually mostly the acute toxicities. You also have cystitis that may occur. We'll cover it a bit later on, maybe in the acute or on the chronic setting. We've talked about proctitis. No, we'll talk about proctitis. We've talked about dermatitis. In the bowel, may have proctitis, which should be attended by. I'll talk about it later. Mostly chronic diarrhea. It may be mucoid, blood stained. There may be a bit of bleeding, fecal urgency, and it may be acute or even chronic. And strictures and bowel obstructions are more characteristics of the chronic form and fistulae. In the bladder, this one I'm also going to cover next, and the vaginal they may also have vaginal stenosis arising, dryness leading to dyspareunia. Sometimes the stenosis is so severe the patients end up with hydroureter, quite a painful experience. They present with low abdominal pain, and this you need to consult the gynecologist for the relief of this. For patients, if you look at the dose, most of the doses go in excess of 70, which predispose the patient to fractures in the bone areas, pelvic insufficiency fractures, especially in the weight-bearing areas, the pubic ramus, sometimes the femoral head and neck. And monitoring of this area is very important in the post-treatment era. The cause of the radiation is also going through the lumbosacral plexomy, the plexus. They maybe have been surgery. You may end up with neuropathy characterized by progressive lower limb weakness. It's a rare complication though. For patients who are surviving even longer, you may end up with secondary malignancy. Most of them are usually sarcomatous in nature. One of the things that usually happen is the fibrosis and skin thickening and epilation at the areas where the beam is going through the skin. This usually tends to be mostly in settings where you use simple planning techniques like 2D planning for the execution of the treatment, and the patients present with a fibrotic pad or the thickening of the skin on the pubis, and also in the gluteal region in the back. And it's usually a concern because patients may think the disease is actually coming back. So assessment usually includes looking at the symptoms, how they're presented, the timing, the ones which are acute, the ones which occur after 6 months, which tend to be chronic, chronic or late presenting. Others even up to 1 year, like proctitis. Thorough physical examination, including that of the abdomen, the pelvic, the rectal, even the primary disease is very important. For patients who they suspect proctitis, colonoscopy may be required to differentiate that either from chronic or acute form. Biopsies may be taken in the chronic form just to find out, is it an inflammatory disease or something else, or is it actually a side effect of radiation. Neurological examination is important in these patients. And then, of course, sterility and early onset menopause is something that has to be kept in the back of the mind. Most of the patients will, especially the young ones, this will hit them very hard, and they will need actually support. For the young ones, you may consider hormonal therapy which may be given until the average age of natural menopause, especially as long as there are no contraindications. But there are also non-hormonal therapies for those who cannot take estrogen, and this include if they're having hot flashes, you may use things like venlafaxine, gabapentin, or clonidine. For vaginal dryness, you might use vaginal moisturizers, lubricants. You need a talk. You need a talk with the patient in terms of sexual health for vaginal dryness. Most patients will want to find out after how long they can actually have coitus, and most of the time you'll have to discuss the timing. Usually 2 to 4 weeks after the completion of treatment, up to about 3 times a week, just to prevent the vaginal, the stenosis. But they will need moisturizers and lubricants, and sometimes low dose estrogens may be required for these patients. and life modification. Some may have insomnia, headaches, things that need to be addressed. So in terms of skincare, many times when you start treatment, it's always good to talk to the patient about skincare at the start of treatment, such as how they clean the skin, not to use irritant soaps, how they dry, not to basically damp the skin. They may also use barrier creams, loose clothing to avoid the rubbing of the cloth over the areas being radiated. We have silicone-based gels, and these ones are in the country that may also mitigate the skin effects, the same side effects. They are applied on the skin, they conform to the skin, and they usually mitigate the occurrence of grade 3 and grade 4 dermatitis. It's good to avoid concomitant injury during that. Sexual health have to be discussed with the patient. Supportive GI for patients who are presenting with GI with gastrointestinal symptoms such as antidiarrheal, hydration, nutritional support using low residue diets. You may have to rest the bowel if it's severe. Hematological, you have to monitor the HB very closely. This also has implications on the efficacy of the treatment. If it's low, the efficacy of the treatment tends to be low, and it sets up the patient for possible recurrence in the future. Leukocyte count, if the persons are getting concurrent chemo, you'll have to monitor and supplement with the Martinix as indicated or transfusion as required. Pain, as per the WHO analgesic data, pain management has to be done with the involvement of the palliative care right from the start of treatment. Other things that form under palliative care include psychosocial support of the patient and also the family and caretakers. Menopause, you have to include things like hormonal therapy. I think I already mentioned this. One of the things that you should not forget is bone density scans for the ones who are actually not into menopause at an early stage. This has to be monitored. Then, of course, you have proctitis. I think I'll talk about it next. It's usually the early form and the late form. Vaginal stenosis and dryness. This is something that also occurs in the late periods. We usually encourage resumption of coitus for the ones who have a partner in 2 to 4 weeks based on the clinical assessment. Vaginal dilators may also be used to prevent stenosis. Topical steroids, as indicated, may be used for fractures, bone health optimization using calcium, vitamin D supplements, biphosphonates. Patients who may even present with bone mets and biphosphonate may also help in that. Pain control. You may also need controlled light strength or resistant exercises. For plexopathy, physiotherapy, neuropathic agents may be employed as guided by the palliative care team. So just a mention on proctitis because it's one of those things that occurs early and also occurs very late, sometimes even years after treatment. For the early one is usually self-limiting for most of the patient. It solves in 2 to 4 weeks after treatment. Sometimes it can go up to 3 months. Supportive care management basically involves supportive care, hydration, monitoring the electrolyte balance. If they have diarrhea, giving antidiarrheal, antispasmodic for the tenesmus, stool softeners to reduce pain during bowel movements. And then if it's severe, you may have to interrupt treatment. And this has to be done in consultation with the radiation oncologist because it has an effect on basically the outcome of your treatment. Chronic proctitis usually tends to be more deeper. It's mediated by damage to the microvasculature, leading to ischemia and necrosis. So it's almost like a full thickness kind of damage. They tend to present with worse symptoms, the same symptoms, but worse. They may have hematuria, they might have fistula formation, they might have perforations, basically, it tends actually to be worse. Management usually involves starting with the least invasive, depending and titrating this according to how the patient responds. Some of the agents that can be used are things like sucralfate enemas, which form a protective lining to assist in healing, antioxidants, especially and anti-inflammatory agents, especially in the acute form and also in the chronic form. In patients who have who have intractile bleeding, argon plasma coagulation may be employed or chemical cauterization with using we call formalin, which is applied to the mucosa directly. You may have other ablative therapies such as laser therapy, radio frequency ablation. Barbaric oxygen therapy is quite good. It stimulates angiogenesis and tissue repair. Then surgical, which is the most invasive, is reserved for when things are intractable. Is intractile bleeding, you can control the symptoms and involve things like fecal diversion or the resection of the damaged rectum. Nutrition is very important in terms of regulating the low fat, restricting lactose, high fiber diets, avoiding irritants such as coffee, alcohol, and spicy foods. And of course, you also have cystitis. The presentation is usually typical urgency, dysuria. Sometimes you may have hematuria if it's very bad, or incontinence, hydronephrosis if there is obstruction of the constriction and obstruction of the urine, the ureters or the bladder neck. You may have hematuria or fecaluria, where there's fecal in the urine. The acute form is usually manifested by inflammation, while the chronic is usually caused by ischemia and fibrosis and tends to be severe. There's a grading. If you look at it, it's very similar, almost similar to the skin, and most of this may be picked from cystoscopy. This is usually the early stages may be managed by conservative measures such as hydration, citrus soda, avoidance of acidic foods or fizzy drinks. You may give anticholinergics if the patient has an hyperactive bladder, but watch out for the systemic side effects. You may also employ intravesicular instillation such as sodium hyaluronate, pentosa, polysulfate. These are things that will have to be done in consultation with the urologist. If the patient is bleeding, cystoscopy may be indicated to evaluate and evacuate clots. Blood education is one of the things that can be used. You may use intravesicular hemostatic agents. Surgical intervention may be required if it's very severe, such as diversion or cystectomy. And hyperbaric oxygen therapy can also be used in the treatment. In the metastatic realm, at the far end, you have complications that may occur because of the disease, such as pain, which may be local or referred, bleeding, bowel or urinary obstruction. If they have patient have bone mets, may have hypercalcemia, you may have bone pains, and these are things that have to be responded to at that particular point. At this point, you are basically palliating, controlling symptoms, and reducing the morbidity of the patient. Systemic therapy is important, is one of the things that can also be employed. Involves chemotherapy. It's attended to by nausea, neuropathy. For nausea, there are actually guidelines based on the metagenicity of the combination of the chemotherapeutic agents that you're using, that guide on which antiemetics you actually use to mitigate that and control the symptoms for the acute MSCs and the delayed MSCs. Patients may also present with neuropathies. They may present with cytopenias because of the agents they're using, and this has to be corrected appropriately. You may use colony-stimulating factors, transfusion, or hematinics. Immunotherapy and targeted therapy are things that are also coming in the use of in the management of this patient in the metastatic area. If it's bevacizumab, some of the patients may present with hypertension. You may have immune-related effects such as pneumonitis and colitis that have to be attended to based on the guidelines. At this point, you have to involve the medical oncologist. They are better versed at managing this. So clinical assessment for the metastatic, I will not probably go into it so much. It's basically in keeping with the normal clinical examination for other complications. But if there's a new lesion you are querying recurrence, biopsy is important to confirm the diagnosis. The goals of care have to be discussed with the patient and the family, and palliative care has to be integrated very early for pain management, for spiritual care, psychotherapy, even sexual health has to be considered. So for tumor-related, of course, for palliative radiotherapy may be used for bleeding, pain. If there's bleeding, uterine artery embolization may also be employed. Pain will be done as per the WHO analgesic data. They may adjuvant or interventional procedures such as nerve blocks, they may be used if these other measures are not controlling pain adequately. Some of the patients may present with obstructions. Stenting or nephrostomy may be required. Sometimes a colostomy may be required if there's bowel obstruction because of recurrent and locally advanced disease. For chemotherapy, toxicity, as I've mentioned, manage as per the guidelines. For neutropenia, give colon-stimulating factor. Neuropathy, modify the dose. You can give certain agents to ameliorate the neuropathic pain. For hypertension, consult a physician. For hypertensives, you may consider changing the regime. Monitor the urine if the urine protein, and discontinue if you have severe proteinuria. And the same thing occurs for immunotherapy, monitor for immune-related adverse effects. Corticosteroids may be employed in the management of these adverse effects, and organ-specific management can be used, such as for infliximab for colitis. So in the survivorship, it's always important to be very keen on surveillance. It is where you'll actually pick a lot of these late presenting side effects like proctitis, can occur even way after 2 years. On the skin, you have what we call recall dermatitis that occurs in the area that you've treated if you give a patient chemotherapy. These are patients, maybe they have been treated and they have a recurrence, or they have progressive disease, and you're starting them on systemic chemotherapy. You may experience some recall dermatitis in the area that was subject to radiation. You have to always evaluate the toxicity of your treatment using the symptoms that the patient may be having, do a pelvic examination. For the ones who need pelvic exercises, link them to the physiotherapy department for the same. Sexuality is a key thing that needs to be discussed. For patients, employ things that mitigate things like vaginal stenosis, discuss with the patient the issues to do with partners. Some patients you may actually find while they're on treatment, they're being pressured by the partners to actually have coitus. So it's always good to involve the family and discuss this, and so that you have a holistic management of this. Spiritual involve the chaplaincy. Some patients may have spiritual needs. They may give psychotherapy for the patient and the family. Rehabilitation is important in the survival area. And then financial toxicity is one of the things that also is never talked about, but is very important. If you look at what Dr. Mugua presented and Afrin, all these things culminate into a lot of financial resources being used for the patients. Some of these treatments are not best in all counties. Patients have to travel, seek lodgings. They have to board with patients. They may have psychosocial stressors. They may have to dig into their pockets, get hostels, all the works. So this is something that has to be really looked into. We may have to involve social workers. Some patients may be unable to afford a treatment, and they may need support so they don't lost follow-up. Then reproduction should be discussed at the start of the treatment, especially for the young patients. I've seen patients where you've completed treatment, and then after treatment you've done your brachy, the patient comes and says they are thinking of having a child, and we realize this was never discussed at the beginning of treatment, and it can be a difficult discussion to have with a patient at that particular point. So it's good to discuss this early in the course of treatment and have measures. If you need to involve a fertility specialist, they should be involved. If you need to transpose the ovaries, that has to be be initiated, to be discussed with the gynecologist. And then, of course, finally, there's care of the caregivers and the family. This is very, very important. So key takeaways, a detailed assessment is usually important. Some of these side effects can be anticipated and responded to early and mitigated. As you can see, it's a multidisciplinary effort. Of key are the oncology nurses. They're the ones who see the patients every day, and they're the ones who pick some of these side effects early enough. And of course, you have the other team members, the gynae, the medical, radiation oncologists, you have the palliative care team, the chaplains, do not forgetting the nutritionists and the physiotherapists. And early recognition of the complications and adherence to guideline management is likely to reduce mobility and improve the quality of life. So thank you.
Thank you so much, Dr. Collins. That was very insightful. When dealing with the complications of treatment, actually most of our patients suffer, but you really highlighted the key points that we can look at. I want us to take a few minutes to discuss the several questions that have come up from our chat box. And I'm starting in no respect order. There is Ahmed Adam, who is posing a very good question. Is there any biological, epidemiological link between breast cancer and cervical cancer? And how can integrated screening programs help to address this? Dr. Afton, you wanted to take this?
Yeah, I can take this. So no, there is no link as such between breast and cervical cancer, not that any literature suggests so. And in terms of how we can integrate, they should basically, or in some places they are being done, they should be integrated both in the existing health the existing infrastructures, basically. Whatever we have, say, we have maternal child health where we're doing via screenings now. We also advocate, actually, and if you look at our guidelines, we also advocate for screening for breast cancer as well. And this is something we need to encourage all the clinicians to do, even for during the, say, because we've seen women who come in for, can I say they come in for screenings or just routine. And so we just need to train the same workforce using whatever data, whatever systems that are already existing, and then delivering basically a unified message that these are cancers that can be treated and we need to integrate them. So we don't need to have different platforms. Let's utilize what we have and integrate both of them together. I think every woman who comes for cervical cancer screening should also be taught, especially younger women, they should be taught at least how to do clinical breast examination for slightly older women. In addition to that, they may require ultrasounds or mammograms, and this is something that we can easily integrate into the existing programs or platforms, and also harmonize with specific guidelines.
Thank you so much. That is quite elaborative. It's all about using proper use of the health infrastructure that we have. I know we've had a presentation on vaccination, but there's a good question that is coming on from an anonymous attendee, and I'd like to direct it to Dr. Mudua, if you can hear me. Why don't we vaccinate men against HPV?
Okay, thank you. Thank you very much. It's I'll start by saying vaccination is for all, both men and women, for boys and girls. The reason why currently in our setup we are vaccinating girls is just because of costs, just that. But if you can afford, I will encourage you to actually vaccinate your young men. But in the national program, the only reason it was put for girls is the cost. We have another vaccine that is another virus that is also oncogenic, and we get it even without thinking, and that is hepatitis B. And it's given to both boys and girls, and it's when the child is less than 1 year. But this one, because of costs, it was now stated that the people at high risk are the ladies. So that's why it was put for girls only. I hope I've answered.
Sure, thank you so much. It's very elaborative. Another good question here. I know time is not our side, but I'll pick the specific good questions that I'm seeing from the chat box. Dr. Afrin, one of our attendees, Ms. Miri Kimani, is asking about the recommendations for patients with CKD who may be at risk for nephrotoxicity, especially with regard to use of cisplatin.
Okay, that's a very good.
In a minute.
Yeah, sorry. So for CKD, we generally tend to drop the cisplatin or the chemotherapeutic agents. The other thing is there's a lot of ethical issues surrounding this. Patients with CKD, would you want to do a renal transplant? Because, there are patients, again, who would benefit from a renal transplant versus the ones such as with chronic diseases. So this is a lot to do with ethics. But patients who have hydronephrosis with kidney disease, we normally divert the urine using percutaneous nephrostomy tubes. We generally tend to drop the chemotherapy. The benefit that chemotherapy confers is about 10% overall survivals. And these women, we opt to do just radiation for the treatment.
Thank you so much. Again, that's a good response and to the point. And perhaps lastly, there's a good question on condylomas with cervical intraepithelial neoplasia grade 2. Dr. Mudua, once again, if you've seen that question, can we do hysterectomy for that? I think either Dr. Fatma or Dr. Mudua can respond to that.
Dr. Fatma, what do you think?
I don't know why we would want to do a hysterectomy. Condylomas are usually outside, so unless you are resecting the vulvas, no, you don't do a hysterectomy for condylomas unless, yes, I also understand that those condylomas that are inside around the vaginal, no, generally we don't. There are other modalities of treatment that we would use, but no, that's not a treatment modality. Surgical treatment would mean excision, but not a hysterectomy.
Thank you so much. I think we can keep this conversation outside this. So if you have any question, you can put them in, and I'm sure Nelson at the right time will spread out to our expert panels, and they will respond back to you. I know there is one here. Someone is asking about HPV affecting the penis. Dr. Mutwai, maybe in a minute.
Yes, in a minute. Yes. So as you've said, HPV can affect the penis. That's why HPV is actually sexually transmitted. Maybe the question he wants to ask, can it cause cancer? And yes, it can. The good thing with our current situation is that the circumcision. So you remove the prepuce, where, remember what I was talking about, the transformation zone. So once you remove the transformation zone, so you reduce the risk of penile cancer by circumcision. The second one is if you have good immunity, again, you reduce the risk. So you can get penile cancer, HIV positive, and circumcised. That's the riskiest group of people. Thank you.
Thank you so much. Dr. Masola, I know I haven't seen most of your questions, but I'd like you to respond to this as you give your parting shot. Do you think in our setting we are doing enough, especially when it comes to assessment and management of complications that are arising from cervical cancer treatment? You answer, then you give your parting shot in 45 seconds.
So I think one of the things that you'll notice is for many of the times, if you look at if you try and follow up patients, even in Kenyatta, one of the things that you'll notice is many of the patients after 1 year, after 1 year, you find almost majority of the patients have dropped off and we don't know where they are. So I think until they present later on with recurrences, or they present with symptoms like hydrometria or vaginal stenosis, or some even present with chronic proctitis. So management of the complication, the acute complications are actually easily managed, where we have protocols, facility-based protocols. They'll pick up most of these things and they'll be actually flagged for management. But where there is a worry is the late presenting side effects. These are patients who, if they're lost to follow-up, they present to a peripheral area where the attending clinician may not be aware that this has been caused by radiation therapy, or it's a complication of the treatment. And many times they'll go through different forms of treatment before they're eventually brought back to the clinician. So I think for acute, yes, there's vigilance, because in most facilities you have protocols that look into this, and patients are seen weekly. But for late presenting complications, there's a paucity in terms of care, given that we don't have very good rigid patient tracking mechanisms in place to know where patients are after, let's say, 1 or 2 years. So majority of the patients are falling through the cracks. Yeah.
Thank you so much, and I hope you've done your parting shot in that. That's why you are responding to that question. And perhaps I'll want to come to Dr. Fatma in 30 seconds. What's your parting shot with regards to evidence management of cervical cancer?
Mine is very simple. So let's prevent this cancer. Treatment is very costly. Let's pick up screening and vaccination, and they're both very safe. Let's dispel all the myths that are surrounding this.
Dispel all the myths, and actually that is the take-home message. From policy perspectives, and the pathways in diagnosis. Dr. Kudua, you did a very, very good work. I want to give you 30 seconds to give your parting shot.
For me, my parting shot will be my key message. Please put for us formally, preserve our samples so that we can give you a good diagnostic criteria for your samples. Thank you.
Thank you so much. Let me take this opportunity to appreciate our panels. They have done really justice to this topic. I'm sure time was not on our side, but they have in a best way they have done to disseminate the knowledge to us. I want to thank the KNHUN organizers for this particular series of webinars. They are very informative, especially when it comes to raising our awareness. There is a concern, Mr. Nelson, from the several chats that are coming on about sharing these slides and how the participants can get their CPD. As I return this platform to you, kindly answer those and then perhaps dismiss us. Thank you so much for joining us. Nelson, can you hear me? Can you hear me?
Hello? We're losing you.
Yes,
if I can just gratitude to the team of specialists and experts that have taken us through this session today, and also to the Ministry of Health and National Cancer Control Program for collaborating with us to deliver to you this awareness series that we've been having this month, and also will flow over to the next month of February. You can see the dates as stated there. Next week, we'll be back looking at palliative care, and it will just highlight how integrated palliative care and psychological support can be given to survivors and patients battling cervical cancer. Do join us for that session. As communicated before, the two previous sessions have been uploaded to our YouTube page. So, kindly take a look at our YouTube page. If a colleague has missed this, you can sharing of the slides.
You're breaking. If you can hear me, Nelson, you're breaking.
Are recorded for that purpose so that you can on. Are you able to hear me now?
Yes, yes, kindly go on.
Can you hear me well now?
Yes. Yes, kindly go on.
Apologies for that. As I was saying, the session will be uploaded to our YouTube page, so you can always follow that. If you are asking for the slides, we do post them so that you can get them at the face value that the presenter intended. To answer your questions on CPDs, kindly note that we do make communication on the CPDs on our email as per the cadre that you belong to. And as we are starting a new year, please note that our CPD processing takes 2 sessions, and we'll be able to communicate to the specific to issue those points. For nurses, we know that NCK codes need to be sent, but our nursing directorate is working on that, and we'll be able to send them to you for your attendance on the attendance sheet. So without much further ado, without taking much, I also like to appreciate our panelists and our moderator for today for taking us through this session. I do wish you a wonderful afternoon and see you next Tuesday as we look on palliative care.